Hey Team, quick, straight talk. Module 1, Foundations of Hospice Care, Nurse-Driven Focus. I'm going to make this simple. Hospice is comfort care, not cure. It's about dignity, peace, real support for families. Most patients qualify when the doctor believes they have about 6 months or less if the illness runs its normal course. Phrase to remember: hospice helps people live comfortably, not get better. Now, money, because families ask. Medicare pays for hospice if the patient qualifies. Nursing visits, meds for comfort, equipment like oxygen or a hospital bed. Families shouldn't pay out of pocket for covered services. Phrase to remember: Medicare pays for comfort care at home or in a facility. Who's on the team? The IDT interdisciplinary team. Nurse, I check symptoms. Nurse, I teach families how to provide care and what changes to expect at the end of life. Nurse, I make sure meds are controlling symptoms. Nurse, I document decline. This assessment and documentation is the opposite of what we've been trained to do. We are not expecting or looking for improvement. We are looking for and tracking the signs and symptoms that the patient is moving more towards the end of life. Doctor signs orders. Doctor reviews notes. Doctor certifies eligibility. Social worker, emotional support and resources. Chaplain, spiritual support. Aid, bathing, dressing, daily care. Volunteer, companionship and errands. Phrase to remember: hospice is a team, but nurses drive qualification. Let's lock in the core message. Hospice care qualification is nurse-driven. My documentation is the proof Medicare relies on. If I don't capture the decline, it doesn't exist anywhere official. What do I document? Decline, symptoms, and interventions. Specifically and consistently. What changed this week?
This month.
Is the patient eating fewer times per day or less of their meals than before? Sleeping more hours per day than before? Having falls? Having symptoms that need intervention and support like nausea, vomiting, pain, constipation, or unable to control secretions? Measure with PPS scores on every patient at admission and at least once per month. Fast for every patient at admission and at least once per month. Weight trends: what did they weigh at admission and monthly if weights are being recorded? Mid-arm circumference measured in centimeters at least once a month. Number of PRN medication used for symptom control, nausea, pain, secretions, constipation, etc. Wound measurements. Oxygen needs. Dyspnea at rest. Hospitalizations avoided. Caregiver burden. I connect the dots. Because of this decline, patient now needs this increased support. Levels of care, also nurse-driven. Routine care, continuous home care CHC, general inpatient GIP, respite. Each level starts with my assessment. I identify uncontrolled symptoms or caregiver crisis, then escalate in real time and notify the physician. Doctors sign off, but my notes are the evidence. Say this line out loud. Seriously. Hospice care qualification is nurse-driven. My notes make hospice possible. Quick exercise, mentally drag and drop. Nurse, checks symptoms. Nurse, teaches family. Nurse, documents decline. Nurse, drives qualification. Doctor, signs orders. Doctor, reviews nurse notes. Social worker, emotional support. Social worker, resources. Chaplain, spiritual support, aid, bathing and dressing. Volunteer, companionship. If you nailed that in 5 seconds, you're ready for the field. Key takeaway: hospice equals comfort, not cure. Medicare pays for hospice services when criteria are met. Hospice is a team. Most important, qualification is nurse-driven. If it's not in my note, it doesn't exist. Before you chart today, ask, what changed? How do I measure it? Did I link it to prognosis and function? Did I justify the level of care? Then document clearly, objectively, and promptly. You've got this. Your assessment gives patients comfort and gives families peace, and your documentation makes hospice possible.